knows the best the use of OCT in the world. So really thank you for Giulio for joining us
to
spend this day with us. So we could have the slide, please. That is a 76-year-old male, and the goal will be to focus on the left main LAD LCX calcified lesion. Next. And you could see on the slide the different risk factors, but particularly non-insulin dependent diabetics. And he has previous PCI in 94 and 2008. And 2008, there was a placement of the regulating stent. He's quite active. Next. And is now he has chest pain during stress, a large positive treadmill stress test at 90 watts. He has the ST depression of minus 2.5 millimeter. Baseline ECG is normal. LV function is normal by echo. Next. These summarize the major laboratory characteristics with a normal serum creatinine, so normal. The GFR is at 75, and but you could see that HbA1c is at 8.2%. Next. They summarize the angiography, and there is a distal, complex, calcified left main lesion. All the proximal LAD, the circumflex is diseased and calcified. It's a trifurcation. Next. And the goal today will be, next please. The goal will be today, la diapo suivante s'il vous plaît. The goal will be today to treat the left main, the trunk, the bifurcation, the proximal LAD, and certainly we will place a stent in the ostium of the circumflex artery. But we decide at the beginning with Giulio to leave the intermediate branch. It's the risk that we take for the patient, but I think it should be too complex if we try to treat all the trifurcation. Next. I think that it's a dominant circumflex artery. You could see that the patency of the stent in LAD, in mid-LAD, is perfect. Next. And this is a very small right, so it's a large left dominant artery. So now we will show you what we have done. Il faudrait revenir sur l'angio. And this is l'angio. This is what we have taken a few minutes ago. And you could see the calcification. Before starting the calcification, you can see very well the stent in the mid-LAD, and all this calcification involving all the left main, the proximal LAD, and the proximal circ, which is diseased. This is in the LAO caudal view. You could see the ramus branch, which is severely diseased, and here in this view, the proximal LAD, which is calcified with a lesion proximal to the stent at the origin of the septal branches. So we did OCT, and Giulio, you can tell us what you have seen before starting the PCI.
So thank you very much, Jean, and good morning. Today we are seeing one of the first co-registration. Co-registration means the synchronization between the OCT and the angiography. That is very precise. If you can see the monitor, you can see some marker that is moving on the middle portion of the LAD, and is showing something that is clearly at the level of the stent. Below you can see the longitudinal view, means 75 centimeters along the vessel, starting from the guiding catheter here, then the left main. Then if you are turning a little bit, you will see the bifurcation. At this point, you may see the circ while Jean is working. This is the bifurcation with the circ at this point and the intermediate branch. Then we are entering on the LAD, and we are arriving in this distal part of the scan inside the stent. The stent was placed many years ago. You can see that the vessel is plenty of calcification. I'm going to show this calcified plaque. For instance, you can see from 5 to 7, but the stent was fully expanded, and he is perfectly covered at some distance of ears. No big tissue protruding inside, and then we made the measurements. Here you can have the automatic lumen detection border, and at this point you know what about the content in the artery, and you can see where we are. If we are moving the marker along the artery, you can see that the marker is moving and is telling you where you are for having precise identification of the procedure. Jean now is dilating the vessel, and then I'm leaving to him the talk.
No, you can continue if you want, because it's fantastic to use this co-registration.
And of course, you can see the 3D images at this point. So in the screen, and turning the axis, you can see all the branches. You can see the branches where there is the rings, and we are going back to the proximal portion. Here is the left main, and then you have the bifurcation at this point.
Okay, any question, Dr. Walker or Hitham?
So John, hi.
Hello?
Hi, John. You had the question regarding
how are you?
the lesion before the medial LED stent. So from the OCT, is that a significant lesion? You had the question about that before at the start.
Yeah. Proximal to the stent.
So proximal to the stent, so the stent you can see is
this lesion. Huh?
So let me do this way. So this lesion here is still the stent, and so what we have is some, well, proximal.
Here.
You are talking about this. So you can see that number one, the type of the plaque, you have a 290 degree of calcium from 2 o'clock encircling the vessel. And you can see that OCT can penetrate the calcium, is no shadowing, and you can see even deeper and below. I think that if you are going to treat this plaque by a balloon, you have a big risk not to be very effective. The area, if you are going to accept at this point, is not very significant. You can tune the distal and the proximal portion.
100.
And this is in terms of area. So let me go to this point. Is about 70% of area stenosis, but is very, very calcified. You can see the calcium is everywhere. So I'm not sure that we need to do something. John, what do you think?
Well, I think the problem is that if we concentrate only on the left main and the ostial LED, we will treat. It's a dominant circ. We will know what we will finish at the end with a 4.5, maybe 5 millimeter balloon for the stent, and 3.5 to 4 millimeter in LED. And I'm afraid that the lesion would appear more severe after the stenting in a proximal lesion. So I will prefer to treat it in order to have an homogeneous, satisfactory result. But again, it's very difficult. That's every time to take this decision. So what we have done is to place a balloon, and I will show you here. It was a 3.5 millimeter balloon in the left main, 3.5 non-compliant up to 20 atmospheres. And now we will advance 3.5 by 38 millimeter stent. So we will start from the ostium. So what we are doing is to go to the LAO-cranio and try to verify if we cover correctly the ostium test. So we are working in the 6 French femoral access because the radial artery was closed. It's a left femoral because he has severe also distal disease, and particularly on the right iliac artery. So it's a 6 French catheter test. Now we are looking if the stand correctly, the proximal edge of the stand correctly treat and cover the ostium of the left main. So we could take a view here, Veronique. I think it's okay here. It's not too bad. And then we will verify I think it's correct. Test. Okay, 6. So now we inflate the stand, 6 atmosphere, 8 atmosphere. We are in proximal in mid-LED, and it's true that we can go up to 18 atmosphere in order to be sure that the stand is correctly open. Of course, maybe it should be enough for the LED, but certainly not for the left main. So here we are, deflation, pressure is good. We have to take care of hemodynamics because it's a large dominant vessel, and the right coronary artery is very, very small. It's a dominant right. So we have to take care of the inflation of the balloon inside the left main. Now we have the jail wire. The LCX wire is jailed by the stent placed in the left main. So I cannot intubate the guiding because of the position of the wire which is jailed. Test. Okay, this is what we have. Of course, it's not very good concerning the quality of the angio. So what we will do now is to take a 4.0 millimeter balloon. Give me a 4.0 non-compliant 21, and a 21 atmosphere. 21 millimeter in length, sorry. Any question or?
How significant was the left main by OCT?
Alors, OCT significance by Giulio, you can.
So here you can see the left main. You can see that the calcification is still involved in the left main. You can see from 9 to 11, huge calcified. The calcified plaque are very sharp in terms of interface. You can see very bright toward the lumen at this point, and then you can see the content below. That is the main characteristic. You have this type of big calcified nodules protruding into the lumen, and then you have at least half of the circumference of the left main that is devoid of any calcification. The calcification is from 11 to 4, while the remaining portion of the vessel seems to be okay. Now we are entering toward the circ. You can see the circ at this point at 8 a.m. And if we are turning while Jean is working, if you are turning the axis, you can see in the longitudinal view the 3 branches, the left main, and then you can see the intermediate branch coming off now. This is the intermediate branch immediately afterwards. Huge calcification, but quite limited in terms of extension in the circumference.
So definitely the lesion is there. It's,
well, absolutely, yes.
So what we have done is to place the stand 3.5 by 38 in left main LED, and now we have just placed a balloon. This is a 4.0 NC balloon up to 22 atmosphere, and then this is the result. I think that after doing this spot, I think we can go up to 4.5, but we will do later. Now what I would like to do is to place a stand now in the circumflex. It's just we have to place the wire, and so I take a third wire. So we have one wire in LED, one wire which is jailed by the stand in the distal circ, and now we will try to place a third wire in the right channel of the circumflex. So what we will do is to place the wire first in the distal, in the proximal LED, and to be sure that, as you see here, that's a problem of the sometimes when we have the gel wire. So I have to modify the position of my guiding catheter and now try to go inside the LED. So here now I am inside the LED and I pull my wire in the close to the ostium of the circumflex. And maybe you can test. And now, from the distality to the proximal, we try to get the passage, and so this is correct. So there is a lot of friction because of this calcification. It's a really heavy calcified lesion, particularly at the ostium of the circumflex artery. So I placed my wire in the distal circ. So this is the white wire. And now what we will do is to remove the gel wire. To do this, because we will have to force a little bit to remove it, I have to disengage my guiding catheter like that. And then I will, in the same time, remove the wire. Okay, that's it. Okay, so this wire is out. And now we will have the possibility, because the two wires are in the right channel, you see, to intubate more and better, to have a better intubation of the left main. We are not blocked by the J wire, and this is now the result. So what we can do now is to have a predilatation of the circumflex. Giulio, 2530. We know that it's a large vessel.
Okay, it is, and if you are just looking to the two-dimensional view, you can see that inside this circ, there was a lot of plaque that is partially protruding. There are calcifications that are protruding into the lumen. So, but the vessel is quite large. We didn't have any chance to penetrate the circ because the pullback was done only on the LED, but I think that 3.0 is the right choice.
Okay, so 3.0, we take a non-compliant. Normally to do this, to open the struts, we take a conventional balloon because the profile is better. But here in this particular case of heavy calcified vessel, I think it will be better to take an NC balloon. So I don't know, I hope that we could cross the struts. We open with a 4 millimeter, and you see there is some difficulty, so we try to intubate more with the guiding. Okay, here we are, and now we can inflate the balloon. We can go to 20.
And we have
Yeah, you see the calcification. Zoom.
We're going to advance a little bit.
C'est bon, stop.
Dr.
We see the
Fajede,
calcification. Yes?
question. Given the amount of calcium that's in the ostium of the circumflex, would you have considered rotoblading it before jailing it with the left main stent?
Yeah, we discussed this before taking the line and the use of the rotoblader. I think that the use of the rotoblader will be interesting in this particular case. The problem is the risk of distal embolization, and particularly in the circumflex. If you have a distal embolization in the circumflex, that could be a problem because it's a dominant large circumflex. So it's a reason why, for safety reason, we took the decision to use only non-compliant balloon. Okay, now you see I can cross it. Go on. Non-compliant balloon. We know that with this balloon we can go up to 25 atmosphere. If we have not the possibility to open it correctly, we will use a special high-pressure balloon, the OPN balloon, up to, okay, here, up to 35, 40 atmosphere. But it's okay now. Look, the quality of the opening is not too bad.
Perfect. Done.
Okay. But it's a very good question. Really, the rotoblader could be used. So what we can do now, it's to take a view and now select the second stent, and we will use the tap technique, the T and protrusion technique, in order to treat this bifurcation lesion. On peut y aller, Bou? Okay, so big shoot, no distal embolization. Now it's not too bad. We can, at the end, we are sure that we will take a 3-5 millimeter stent for the circumflex because it's a large dominant.
Very big.
So what we could do is to take a 3-0 and go up to 3-5. It should be easier to cross. Concerning the lens, Giulio, that's a problem. What?
Well, let's see the rewind. I think that probably 20 could be enough.
Yeah.
Or do you want to have more?
Yeah, 18, 20.
18, 20.
Okay, maybe to 18. So 3018 stent. It's a DES. It's a Xion stent. Really, it doesn't matter. It could be done with any type of new generation of DES. The problem is more in the quality of the plaque preparation with very high pressure, non-compliant balloon, or the use of a special device, as you say, with rotablator. And then a post-dilatation, which will be very aggressive after the stent placement. And then after that, we will control, if we have time, I hope that we will have the time to show you the OCT control and using this fantastic tool, which is the co-registration, OCT angio. Okay, so we are arriving with the 3018, and it's smooth. It's very good. Okay, so now we can give me the 40 balloon, if I can. What we will do now is to change the view and move to the LAO caudal, what we call the spider view, like that, in order to see both balloons. Okay, here. So 40, we have used this before, so I'm a little bit afraid of the possibility to use this in the 6 French guiding. We will try, I'll reshape a little bit the balloon. If not, I will take a new one. It's quite difficult. If not, I will take a new one. Ouais. Give me a new one. It's donnez-moi un 4-0 compliant, hein, un compliant.
Garde le guide. Hein.
Yeah.
Tu l'as?
OK.
Voilà.
Yeah. 4-0
ouais.
par 15.
Ouais.
4-0 by 15. Okay, during the preparation, if you have any comment, questions?
John, you showed an excellent demonstration of how to enter the side branch by using a hydrophilic wire going into the distal main vessel and then trying to get into the most distal strut of the side branch, and you made it look very easy with the steps of once you get into the side branch, you remove the jailed wire, you pre-dilate the struts, and you go in with your stent. So beautiful demonstration.
You know that, I mean, Ethan, we know that the use of the proximal optimization, what we call the wire is out. No. It's the other one. No, sorry.
Anybody from the audience has any comments?
No, it's okay. You know that what we call the optimal optimization, the proximal optimization, is very, very important, and this really facilitates the placement of the wire in the side branch. So I have some resistance, but it's normal because we are in 6 French guiding. I think that c'est pas peine injecté. Okay, now we have you see the balloon in the left main LED and the stent in the circumflex. So now what I have to do is to remove a little bit the stent in order to have a little protrusion, not too much, but a little protrusion. I pull back a little bit my guiding. Here we are not too bad. Now we will do the test. No. Go on, test. Maybe it's a little bit too much. We can advance a little bit. So we have time. We have time to take this view.
Okay, it's too much.
Yeah, I know, but you know, every time, and when you push every time, one thing, you push to advance one balloon, the other balloon is moving in the opposite way. So, okay, we take a view again, we film it. Oh, very good. I think it's good.
Yeah,
What do you think?
Looks good.
Correct.
It's okay.
Okay, so we can inflate first the stand. 6, 8, 10, 12, 14. It's a free zero, you can go to 16, 18. Okay, stop. Now, I will pull back a little bit the balloon of the stand inside the left main here and take 21 atmosphere. So the free zero, gone. We take 21, and then after that, we will postulate at 3.5. Okay, 21. Okay, deflation, you can take 6. We can try to do now a kissing balloon, 8 and 8. So it should be 4-0 and 3-0. So it should be not too, it should be good for the, okay, very good. 6, 8, 10, 10 on both.
We got it.
Okay, got. Problem will be I have to advance a little bit the balloon of the LED here, and we do the same thing.
Okay.
8, 10.
Good.
So now we have 2 big balloons in the left main, so this is good to open it, stop, and then finally we will finish at the end by the left main inflation using certainly a 4.5 or 5 millimeter balloon. So this is the, we can remove the balloons.
4.0.
This is, we can remove this one.
And done with the second.
Yeah, I think,
Okay.
Dr. Fajade, that was an excellent demonstration
now
of
we
the
can take a
pot
view.
technique.
The wire, eh? Wire. Keep the wire, eh?
C'est bon, c'est bon.
On the,
Non, c'est
on
bon.
the
On y va, Bou? Shoot. Now, that's quite good, and at present time, the intermediate branch is still open. So now I think, Giulio, what do you think? It's maybe to optimize the quality of the result, particularly on the circumflex.
Let's have another injection.
I can do. Well, on this view,
I
I
think,
think
it's
so.
I think it's no bad that we can use a 3.5 non-compliant,
Yeah.
75
Yeah, it's got
non-compliant,
a 3.0 millimeter balloon, so we can place a 3.5
3.5
NC
non-compliant and see.
and the 4.0 on the side.
But then it's no bad, and then we will scan the LED.
The problem will be to be sure that we have not, we took a 38, but is there any gap between both stands? That's
We need a
another point on the LED. Can we see it?
We're injecting now.
OK. Pas immédiatement. Vas-y. Yeah, certainly there is some gap in between. So what do you think? You need to place an additional stand in between, or leave it like that? Maybe we can leave it. Huh?
I think that I'm going to
We
be
will check with
concentrating, yes, and we are going to be concentrating on finishing the left main first.
OK.
And then we will be back and we will see with the OCT, with the last scan of OCT.
OK, so we come back to the caudal. In order to place a 3.5
No,
millimeter
before
balloon,
3.5 non-compliant.
NC balloon,
3.5 non-compliant. Pour,
3.5/9 par 21.
on stay back.
Voilà, ça sera...
Super.
OK.
Ça me semble très très bien.
OK, here we are.
Dr. Fajade? Can you hear
Yeah.
us? One of the questions we have is, what is your anticoagulation regimen and antiplatelet regimen now?
At present time, the patient was preloaded with 600 milligram of clopidogrel. He received this morning 2 tablets since 2 days, and he will be treated with 2 tablets per day for 1 month, followed by 1 tablet per day for at least 1 year. That's the treatment we use for the complex bifurcation when we are using a 2-stent strategy. Of course, we could use the new generation of antiplatelet agent, prasugrel or ticagrelor, but what we are doing, we're still using for stable patient. And again, this patient was quite stable. He has the only angina class 2. Go on, you can go. Okay, sure. And we are using the Plavix. We use prasugrel or ticagrelor for the acute coronary syndrome. So,
let's go back a little bit.
What was the
millimeters back?
Yes, what was the pressure? Okay, here we can go.
Going.
We can go up to 20 atmospheres, 3.5, NC balloon, very good.
And your anticoagulation is heparin?
I don't know. It's a branch, I think.
I think so.
Sorry? Anticoagulation now?
Yes,
it's just IV heparin.
I think I like that. Your cases are always very practical.
Le 4.0
heparin
balloon.
And clopidogrel.
NC balloon, tu l'as? Celui qu'on a utilisé tout à l'heure. Il a pété? Oui. Donnez-moi l'autre 4.0. 4.021. Pêchez-vous 35.
Oui.
4.021, sinon vous donnez un 9.
Ouais.
Oh, putain. Okay. So 4.0 balloon. So now we do the cosine with the 4.0 in LAD, left main LAD, and 3.5 in the left main LCX. So we have two, both of balloons are non-compliant, and so we hope that the result will be fine.
The other ones, we take this one.
Okay, so the 4.0 is coming.
Mm-hmm.
Maybe the wire is a little bit twisted sometimes, and particularly with the big balloons, we have some difficulties, but this is okay here. We can check in the caudal view, but I think it's okay. We could remove a little bit of 3.5.
And advance a little bit in the 4.
Here. And a little bit the 4.0 gain, because it's quite distal. Attends, il y a un problème. Attends. This is a circumflex, which is good. And now I pull back the LAD. Okay, it's okay. 6 on both. 8 on both, no more than 8.
Okay, done.
Stop, down. Pressure is correct, but we have to deflate the balloon quite early, because if not, we get a problem. Again, that's a left dominance system. So the problem I have here is that the wire are twisted. So I will remove one balloon after the other one. So this is the first one. Interesting. And the balloon is in the, okay, so I remove everything. I remove everything because the balloon was broken in the guiding catheter. So I prefer remove everything. Okay, so now, give me an autre guiding. Donnez-moi un autre guiding, s'il vous plaît. Vite, un autre guiding cathéter, le même guiding. Okay, I would prefer to change everything because the balloon was broken in the guiding catheter, so I don't want to... no, there is nothing inside, but for safety reason, I prefer to change everything. Donnez-moi un BMW, s'il vous plaît. 9.
On va dans le professeur.
Okay, so we will change the guiding catheter. Tu es à fond?
Ouais. Je l'ai.
You see the aorta also is really calcified. Okay, here we are in the left main. Flushez, s'il vous plaît. Flushez. Very good. Flushez encore. Okay, we have a good flush test. I prefer to change everything okay, perfect. So now what we can do is to place a single wire in the distal LED. With the single wire, we will check all the mid-proximal LED and the left main bifurcation. And at the end, I will finish with a single balloon, short balloon, in the proximal left main in order to be sure that particularly the osteum, the struts at the osteum are correctly open. Because when we are doing this kind, very good. So you could see that it's open. Huh?
You largely open.
Okay, everything is open. That's good. Okay. So now OCT. We can take a view.
No, we changed the view. We needed to have less overlapping of the view. And we are talking about, with Jean, we were talking about how to select the angiography view for co-registration.
We can do this one also.
Absolutely. No? And we wanted to say that you needed to select a view where you cannot have too many crossing branches through the main vessel, because otherwise your co-registration is going to be partially missed. So we are going to take this AP extracranial view. Okay, and so Jean, the catheter is ready. We can advance. At the same time,
so the left
Jean
is
is
open.
advancing.
Dr. Fajide?
Yes?
We have a technical question. For OCT, do you inject contrast by hand or by automatic injector?
I usually inject contrast by hand.
I'm usually using an injector.
But normally we have to use, it's better to use a contrast injector. So I use usually by hand. Okay, here.
Because you are a strong man.
No, but...
Okay,
is it okay for you here?
Yes, so we need to do auto calibration. So you have to understand that everything we are doing is under the control on the table, because we have a table side control. And so we are ready, Jean?
I'm ready. I can see it.
So you have to push very hard. Yeah.
It's done. We have a larger malposition proximally, but we will check later.
Yeah.
So number one is very important when you finish to do the co-registration. So you needed to go to this green button
5 mm ballon.
and then select from the distal to the proximal the pathway that you wanted to have a co-register.
Non compliant.
Then you press continue. The system is asking to confirm, always from the distal to the proximal. Then the system is making the synchronization. Few seconds, normally even less of the time we are waiting today, but and now is showing the pathway. I hope it's coming, okay? It's telling you exactly from where, so the vessel is okay. So here we are inside the old stent.
Yeah.
You can see the calcification. Now I'm going back.
And you see the white marker, and Giulio, maybe on peut le montrer ici, from the joystick here.
Okay. So on
this, Giulio is manipulating this joystick here. Vas-y, tu là.
So
and
this,
you can move the placement of the white marker you see on
and
the
it's synchronized. So what we are seeing in the 2D-dimensional view and the longitudinal view is exactly the point. When we are crossing some branch, is becoming red due to the fact that there is some insertness, and then we are going back. So quickly, we are checking what we have done today. So this is the new stent that has been placed. The plaque in between is not important at all. So there is a small, I think, minimum gap, but it's okay. So here you can see the stent that we placed today. We are talking about the distal portion. It's nicely placed. All the struts are okay. Here there is a bifurcation. You can see where there is the carina. So here at 7, 8, you can see the opening of the diagonal branch. Then we are going back. You can see the calcified plaque that is behind the stent. There is some malposition. And eventually, if you want, you can go here. You can click on the lengths. It's asking to calibrate the system to have the right measurements. And then we say accept. And we are going to make the distance of the maximum malposition. So from here to here, let me see. So we are talking about 300 microns, and then you have to remove the thickness of the struts. So it's not very big, this malposition is for some segment. Here we are going back. Here you can see the struts, they are protruding. So this is the new carina at the level of the bifurcation with the circ that is very, very big. You can see how big we opened the circ from 11 to 2. And then you can see the two carina, the ones on the left main LAD and the ones on the circumflex at this point.
Est-ce que je peux avoir l'angio, s'il vous plaît, sur l'écran? Mais oui.
And perfectly placed inside the left main.
On n'a pas besoin de nous voir. Montrez l'angio, s'il vous plaît.
Now I'm going back, I'm switching back to Jean.
No, continue. I was talking with the technician to look at the angio. So what we will do is two things. First, we will do the post-dilatation, but proximal to the tap zone. I don't want to be, in the tap zone because I will crush the circumflex stent. So I have to be a little bit more proximal to
the point of the
to the zone. Yeah. And then what we could do is to place a second wire and do a kissing again with the 4-0. Here we have a 5-0. So we can inflate. Vous avez inflate here. I am proximal to the tap zone. We can inflate here at 16 atmosphere. It's a 5-0 balloon.
It is okay.
Stop. Okay, and now I will place another wire in the circumflex in order to try to correct the malposition in the proximal LED. It's what you say, eh?
Yes,
proximal
exactly.
LED.
And you can see where is the proximal malposition. So you can see the 2D images at this point, and you can watch on the angio where is the point of the malposition.
Yeah.
So you have exactly the position in your view.
So here is the LED wire again. So we can fix this here with the blue.
It is after the bifurcation, eh, Jean? You can do even without recrossing, if you want. Because it's after the bifurcation, so we can do even without a recrossing eventually.
But I'm afraid to, if I am doing a mistake, I can crush my LCX stent. So I will try to place the wire in LCX, place a 3.5 millimeter balloon. 3.5 millimeter balloon in the LCX. It could be a compliant balloon, no problem. And then what do you say, 4.0 in proximal LED or larger?
So the lumen is 386, but the vessel is more than 4. So I think that 4.0 in the proximal LAA, it's okay. So normally we are taking a couple of measurements. One is on the lumen, but the second one we are trying to watch to the media to media. Here, for instance, you may see while Jean is working, how we are measuring the media to media, because here you can see that you can measure, you can measure the media to media. Let me take this point available.
Non, c'est bon, préparez le 4-0, s'il vous plaît. 15, c'est bon. Compliant, hein? Okay, here we have the balloon.
While Jean is working.
Et 4-0 here, 4-0 on the...
4-0, c'est bien.
Ouais, okay, so 4-0 for the LED, Giulio?
Ouais. And you know why you have...
Yeah. So we have the point you see on the screen where we have to inflate the balloon. So it's true that in this particular case, should not be mandatory to place the balloon in the circumflex. But if the balloon is moving back by mistake, and we could have the possibility of the crash. So I prefer... Yeah. Okay, here we are. We have the balloon here. And the balloon is in the circumflex here. And now we have no problem. So we take exactly the same position with areolo and cranial. And you could see on the screen that we have the marker, and we inflate the 4mm balloon test at the site, at the site of the marker, to be sure. That's good, huh?
That's okay.
Okay, so le 4-0. Inflation of the 4-0, 16, 18 atmosphere. Okay, here we are, descend 14. Now we can inflate the circumflex. So we will do a sort of kissing. And to protect, and we can go up 16 atmosphere on the circumflex.
Okay, done.
Okay, pressure down on both. Very good. And now we are sure that we have achieved, really our best for the patient by this optimization of the quality of the stent deployment. It's true that we could anticipate at the beginning that the vessel will be a 4-0, but it's true to say that the use of this co-registration can show you exactly the point of the malaposition. And this is really fantastic to see that. And it's really easy to use. So of course, Giulio is an expert, but to be honest, I tried this system several times in the last weeks, and I can tell you it's really easy to use. And okay, here now is the result, and you could see now the quality of the vessel, the lumen. Huh? Okay, so what we can do now is to remove, and because I know that we have to leave you, the line of the satellite will be closed in the few minutes, few seconds. Yeah, and so I will give you this final result.
Let's go to the other ones.
We can check in the LAO. That's very good. And now with the final check in the LAO caudal view. It's correct.
Perfect.
Very good.
I think it's okay.
That's fine.
Questions?
SHA-MC, we took again. I think it's good because you see zoom. Yeah.
I think is.
So we are lucky because you see the ramus. Look at it's still there. There was at the beginning a lesion at the osteum, but the ramus is still there. And this is the final result we have.
Dr. Fajade?
This is showing the LED. Yes.
We would like to thank you for taking the time, and if you can give us your closing remarks, that will be great. We saw a wonderful result, and it's the first time I've seen on my, personally, co-registration with the OCT, and it's wonderful. You know exactly where you are and where you have to post-dilate and fix. So please go ahead.
No, first of all, I would like to thank you for this opportunity that you give to all the team, to our team, and to demonstrate the treatment of a patient with complex calcified distal left main lesion involving the LAD and the circumflex. We use the TAP technique. We try to show you the different steps, and we have to work step by step with a plan which was decided before starting the transmission. And we use in this way the TAP technique because we consider, all of us here, that a two-stent strategy was better in this particular patient than a single-stent strategy because of the disease of the coronary arteries and the diffuse calcification. And you saw that at the end, the size of the balloon that we use, and I think this is very important for you know, the post-operative period, and to try to avoid the risk of stent thrombosis in the first days following the procedure, but also particularly to avoid the problem of late or very late stent thrombosis and restenosis by the quality of the stent deployment. It was fantastic today. It was really a fantastic opportunity to have Giulio Guagliumi with us in the lab. He has a tremendous experience in the OCT and particularly in this new technology with co-registration, angio-OCT, and it was really easy to manipulate when you are doing these kind of things. Really, it was amazing to see you manipulating this. It's and again, I think it's really a plus, a bonus for the quality of the result that we give to the patient when we are using this kind of new technology.
Dr. Fajade, thank you. Our time is running out.
Giulio.
So
I think we can applaud Giulio. It's a fantastic guy. Yeah.
Thank you.
Really. Thank you. And really thank you, all of you, for giving us this opportunity to share these minutes of your meeting, the SACIS meeting in Saudi Arabia. Thank you very much.
Thank you very much.
Thank you.
See you soon.
Thank you, John.